So I thank Delhi Orthopaedic Association and Pediatric Orthopedic Foundation for having given me the opportunity. I'll be talking about the forearm fractures, what is acceptable. And I will start off with some anatomical facts, some embryological facts, and some physiological facts. Follow it up with some important papers, relevant papers. Follow it up with some case discussions, and then conclude. So talking about the epidemiology, we find that 45% of all these children's fractures constitute these, 62% of the upper limb fractures, 81% in children more than 5 years of age. Peak incidence of the distal forearm fractures is between 10 and 12 in girls and 12 and 14 in boys. Distal 1/3 constitutes 75 to 84%, middle third 15 to 18%, proximal third is 1 to 7%. More than 50% of these fractures are green stick. And talking about the ossification, the primary ones start at the 8th week of gestation. Distal radial epiphysis occurs around 1 year in both the sexes. Separate center for the radial styloid may be present. The distal ulnar epiphysis, 2 centers at 6 years for both. Physial closure of the distal radius occurs at 17 years in girls and 18 to 19 years in boys. Distal ulna, on the other hand, closes at 16 to 17 in girls and 17 to 18 in boys. And we have to realize the importance of the annular ligament in especially the proximal fractures, and the role of the triangular fibrocartilaginous complex in the distal fractures. Then we also have to talk about the deforming muscular forces. The proximal 1/3, the biceps and supinator are very significant. In middle third, pronator teres comes into play, and in distal third, brachioradialis is important. And talking about the pronation and supination, we need to understand that the rotation of the radius on the ulna has a mechanical axis from the center of the radial head to the ulnar styloid. So what is happening is it is actually projecting a cone when you are doing a pronation supination. And rotation of the forearm is the motion most frequently lost after these fractures. As per Matthews et al. Was recognized way back in 1982. And also in Christensen way back in 1964, talked about maintaining adequate interosseous space, restoring the interosseous distance with the forearm in neutral to 30 degrees of supination, which is ideal for regaining full rotation. Acceptable alignment of forearm fractures in children is controversial. You know, that came into the picture when the famous paper by Price came in 2010. But at the same time, he talked about malrotation may be judged by obtaining a radiograph of the intact forearm in a position similar to the proximal fragment of the fractured forearm. There is no confusion here talking about a few cases. This is a 14-year-old boy who has a fractured forearm. And here, most of us would agree that probably requires an internal fixation surgery. Again, we talk about another case. There's a 4-year-old, a younger child with a fractured forearm with a volar angulation. And these are the two, and that's the pre-op. And on the right, we have the post-op. We did a closed reduction, put a cast, and this kid did well. But here is a 6-year-old where a closed reduction and POP was done. And this kid ultimately was immobilized in a mid-prone position. And that was the thing, and it actually remodeled. And there is another 6-year-old which actually had a green stick fracture with a volar angulation. This was mentioned by the last speaker, Dr. Manoj. And here we did an osteoclasis, had a good alignment. But what's important is we immobilized this in pronation, because most of these volar angulations are because of supination injuries. Reduction in full pronation and full supination is rarely necessary for completely displaced shaft fractures, but pronation may be appropriate for green stick fractures that present with volar angulation. That was one of the conclusions by the Price paper in 2010. This is an 11-year-old with a swelling of the forearm where an open reduction and internal fixation was planned. And this kid had a lot of swelling. So we decided on taking a small incision and, holding on to the fragments of the pins, and at the same time trying to release the fascia so that we reduce the compartmental pressures. And we wanted this kid to come back after 2 weeks so that we remove the pins and mold it and give it. But unfortunately, this was the immediate post-op. And finally, the kid came back after 10 of 2 weeks, and the pronation. So you need to be very careful when you are trying these things. Sometimes these pins can act like a very rigid kind of a structure if it is continued for a very long time. But what about this scenario? This is an 8-year-old where most of us would think, now when you do this, when I did this particular reduction, it seemed to be a very stable. There was a very good alignment, and we put a plaster. And after that, this kid actually went on to heal very well with a good alignment. But the crux here was, what was the crux? The crux was we changed the whole cast into a very snug cast after 2 weeks, taking care that all the angulation and the interosseous space was maintained. We also need to be aware of these special circumstances where there is a plastic deformation of the ulna. And these are extremely difficult to reduce on an OPD basis. You need a conscious sedation or a good relaxation by general anesthesia. You need a sustained 3-point pressure to reduce these fractures. So according to Price, in 1990, complete displacement combined with mild angulation or malrotation may compromise motion to a greater degree than complete displacement alone. So the combination could be something which we need to look out for. And in Price in 2010, talked about surgical stabilization should be strongly considered for all displaced fractures of the proximal third of the forearm shaft in children older than 6 years of age. So his cutoff was, in proximal third, cutoff was more than 6 years of age. And Price, again in the same paper, talked about when secondary reductions were required under general anesthesia, he recommended use of intramedullary fixation to avoid repeated returns to the operating room for reduction. So in this case, for example, in this 12-year-old, the intramedullary nails were a better option. So this is the paper in which the conclusion of Price in the 2010 paper, he talked about the acceptable early alignments of the displaced radius and ulnar shaft fractures. He talked about the mid and distal shaft fractures in children less than 8 years of age, where less than 15 degrees of angulation was acceptable, but up to 20 degrees in less than 5-year-olds. And in children more than 8 years of age, but with more than 2 years of growth remaining, he accepted less than 10 degrees of angulation in the mid and distal shaft fractures. But in proximal shaft fractures, less than 10 degrees of angulation was in children less than 8 years of age also. But in more than 8 years of age, anatomical reduction with internal fixation was recommended. But after that, in 2011, there was this paper by Bowman, Ian et al. In JPO, where he talked about the non-operative treatment of both bone forearm shaft fractures in children and predictors of the early radiological failure. And this was a retrospective study on 321 patients with complete fractures. Thresholds for maximum acceptable angulation for male patients was less than 10 years and female patients less than 8 years were as follows: 10 degrees of proximal third for proximal third, 15 degrees for middle third, and 20 degrees for distal third fractures. For female patients, more than 8 years of age, and male patients more than 10 years of age, up to 10 degrees was considered acceptable in all levels. But the conclusion was very interesting. Children with 10 years of age or older with proximal third radial fractures and ulnar angulations less than 15 degrees seem to be the highest risk for failure when treated non-operatively for both bone forearm fractures, as the majority of the failures occurred early. Early surgical decision making is encouraged. Now, most of you would be thinking about the fact that why less than 15 degrees of angulation of ulna? If you remember, Dr. Manoj also mentioned that sometimes a straighter ulna could act like a kind of a strut, which can actually be a kind of a hindrance for a proper reduction of the radial fractures. So they found that it was a very strong factor which actually influenced in their paper the future of the alignments being maintained. So most of the alignments which got affected were in those patients where the initial angulation of the ulna was less than 15 degrees. So that's an interesting point, which is something to be thought about. So take home message, get the x-ray of the normal side. It's very important, get into a habit, get the x-ray of the normal side, because one has to be thinking about what is going on with the interosseous space. One has to be thinking about what is the normal radial bow, which is a very important factor you have to take into consideration in order to get a proper outcome. The second thing is flexibility to acceptance of alignment reduces as patient's age increases and when we proceed from distal to proximal third of forearm. Take green stick fractures seriously. Now, there was this question to Dr. Manoj. When I was training in KGMC Lucknow in my MS Orthopaedics, my guide used to tell me, Dr. Professor U.S. Mishra, who is no more now, he used to tell me that any green stick fracture which comes to you with a visible deformity, please correct that deformity, because that is going on, that will go on to a kind of an unacceptable alignment. You know, that was a very crude way of describing things, but as Manoj said, that we have to understand these green stick fractures, whether they are volar angulated or dorsal angulated, and treated accordingly. For example, volar angulated green stick fractures need to be immobilized in pronation because it's a supination injury, and so on and so forth. So you have to understand the mechanism of injury. Pronation or supination are the commonest movements involved. This is very important. We have to understand that. After close reduction, change of cast is imperative after 2 weeks. It's important to understand that the initial cast might be loose, and sometimes you deliberately put a loose cast in order to take care of the swelling. But at the same time, you have to be aware that the fragments need to be properly manipulated if necessary in terms of loss of angulation, and we have to maintain the interosseous space after 2 weeks so that you get a good outcome. Surgery should be strongly considered in children more than 10 years of age and with proximal 1/3 of fractures. Thank you very much.